level, and we all understand this. Anyone who's spent any time out of work or on benefits knows that it restricts your choices. It limits the amount of income you have and those who depend on you have. It limits your choices in life, the level of autonomy that you have. And yes, it has a direct impact as well on your health and well-being. So whether someone's in work or not is important at the individual level. At a community level, it's important because they spend that money they earn in those local communities. And that's what keeps villages and high streets alive and vibrant. And at a slightly higher population level, it's important because people who are in work fundamentally pay more tax. And that tax funds the public system. And at a national level, that is the kind of paradigm in which why economic productivity is so important. It is the premise on which our entire welfare state is laid, is that people do work and pay tax, and tax allows us to help those that are in most need across society. So this is at the very essence of what public health is about. Ill health costs us a lot of money, and there's a direct link between health and productivity. And these are some of the infographics that are available online for you that PHE published earlier this year to try and bring together data in a simple way that just made it a bit more visually accessible in terms of the scale of the challenge around health and work to employers, but also pulling out specific aspects around older people in employment, younger adults in employment and particular conditions. The link between health and sickness absence seems a very logical one. It's one in which the evidence base is actually quite variable. Not so much about sickness absence, productivity and presenteeism, those people who come to work when they really should be staying at home, being ill and recovering. But actually the evidence base about what to do about it is a bit more variable, and that's where some of the challenges lie. In terms of the context of unemployment, it's very easy, I think, to kind of take a very negative spin on the situation. But actually, in general, unemployment nationally has been declining. And that's been an onwards trend over the last 10 to 20 years. And quarter on quarter, we see a decline in unemployment. Now, there is a caveat to that, and I'm sure many of you would say, well, what about zero-hour contracts, different ways of defining employment? Well, yes, that is part of the picture. And there's a really mixed message around whether things like zero-hour contracts are good or not. And when we look at it nationally, we look at some of the consultation responses to the Green Paper and Health and Work around things like that, it's very mixed. For some people, it works very well. For some people, it is not working at all, and they feel they've got a loss of autonomy and an instability, and particularly a lack of job security. And we know from the Marmot work around good work that job security is one of the things that's important to a concept of what good work is about. One of the things I want to just pull out on this slide, if I can get that pointer to work, is this bit at the bottom about economic inactivity. So at a national level, when we look at what can we do about health, wealth and productivity, this bit about unemployment rate is about getting people who can work and want to work into jobs and job density and job opportunities. The inactivity rate is reflecting people who are currently not able to go into work. So they're either choosing not to be job seekers or they're unable to because of other responsibilities. And there are basically four categories of those. So there are people who are studying, people who are caring for family members, people with ill health, and people who retire early. So of these four, we want people to be studying, we want people who've got caring responsibilities to be able to provide those responsibilities and support to people in their families. Whether we want people to retire early or not is a bit of an interesting question. We want them to retire early if they can afford to retire early. But the one we can actually change and influence is the people who are unable to work because of ill health. And that's why you see a lot of the focus on what we call closing the disability employment gap. So looking at how can we help people who have health conditions get into work and remain in work, and work that is good for them and pays them a reasonable wage. Because actually all the market research and the surveys from the disability charities show that people with health conditions, people with quite severe and complex disabilities and impairments, want to work. The challenge is not generating the appetite for work, the challenge is generating the jobs that are appropriate for them and helping employers in the system to see the potential of these individuals. In terms of health-related welfare, It's a significant cost to the government. So yes, there is a financial narrative around this about why we want to close the disability employment gap. But I have to say, honestly, at the national level, in discussions with senior officials and the rhetoric we get back and the narrative from ministers, and one of my kind of interesting learnings as I move from local government into working with the national agency is when you get back things that ministers hand write on. It really is quite an interesting insight to how government works and that concept of democracy, is that ministers feel very personally that this is an individual issue. This is an individual issue because it's an issue about people's lives. So there is a very personal narrative from the top down around this in government, that this is not about the cost of benefit. It is part of the conversation, but it's not the driving factor. The driving factor is actually we're not doing the best for people. We're not supporting people to have the opportunities they could have if we enable them to get into appropriate and safe work. And this narrative played out in the Green Paper. Can I ask you all to stand up, please? It's a PhE health event, so we expect to see a bit of physical activity in it. So if you read the Green Paper on health and work, called Improving Lives, can you sit down? Okay? So everyone who's standing, that's a bit of homework for you tonight. You can sit down again. So the consultation's now closed on this, but it's still really worth reading. It's not a massive document, and it's a pretty easy read. And the reason I say to you this is really important homework for tonight is I think this is one of the most fundamental public health government policy papers there is. This is a Green Paper which puts people at the centre. It puts the narrative around why health and wealth and productivity is so important at national and a local and individual level out on paper, and it raises a whole load of questions about how we as national government, local government, the NHS could do better in this space. So it's a really important thing from a public health perspective to be aware of. And this diagram kind of summarises the approach in terms of focusing on when an individual is looking for a job, have we created jobs that are secure, that allow progress, support them and keep them safe? Have we got action for when they fall ill in work to help them to return to work safely or to move careers and change roles? If they turn to the NHS, are we doing what we can within NHS services to support employment as a positive outcome? When I was talking to Royal College of Physicians last year about this, I said, how many doctors in the room ask your patient every day, patients, every time you see them, what do they do for work? And they all stood up, because I made them stand up as well. And I said, okay, how many of you asked for something other than occupational exposure? And they pretty much all sat down. And the interesting thing was when I said, well, what do you ask about? What's the thing in your head when you're asking about occupation? What is it you're thinking? And the story is, and any medics in the room will relate to this, we're asking because we want to know if they make paint and dye. And we want to know that because if you manufacture paint and dye, you've got an increased risk of bladder cancer. And that's the stereotype that we're taught at medical school. So that's why they're asking about employment. They ask it, but they don't think beyond that. And one of the challenges is how do we help healthcare professionals think, I'm asking this question anyway, but if someone says, I'm not working, or I used to be, then asking them the follow-up question, and has your health been part of the issue that you're not working anymore? How can I help you around your health if it's a barrier to work? Because we've got physio, we've got OT, we've got psychotherapy, we've got those services in the NHS, and having gone out and met with them and talked with them, they're really keen to help and support. But that referral connection, that connection for a clinician between I'm asking about your occupation as a holistic assessment of how you're coping with your disease, how you're recovering or how badly your disease is affecting your life, is a simple logic step, but not necessarily one that we're training people to do or helping them realise. So there is a programme of work starting on that with the College of Occupational Therapists at the moment. I think we've got a range of OT champions in the patch, and I'll make sure Sue and the team have got the names and the hospitals they're in, to try and help clinicians see that logically. So how can we make sure that healthcare professionals support people to achieve their potential? And if they're out of work, how can we make sure that we think about the opportunities and what work might be appropriate, and give support through Job Centre Plus to a more structured, more sensible conversation, more practical conversation. We've all seen the kind of tabloid headlines around the horror stories where people are being given really inappropriate advice. And the sad thing is that often you get one horror story which everyone knows about and hundreds of thousands of success stories that no one ever wants to report on. But we could do better in this space. And if people are inappropriate for them to find paid employment, how can we support them in a way that's useful, that gives them opportunities to contribute to society and take part? So I'd really commend you to Google that tonight and have a look. It's a really short read, but it's a really important one. The government will respond probably over the summer to it, and you'll start to see pilots and innovations starting to roll out quite quickly, because there is a very strong appetite for ministers to be seen to be doing stuff in this space. What is out at the moment is the industrial strategy, and then another one for a quick read. This consultation closes in a couple of weeks, and this is talking about how do we move forward the powerhouse of UK PLC, particularly in that context of Brexit and the Trump administration. And there are 10 pillars, and pretty much across all of these, health can play a role in terms of supporting people to engage in the space, to making sure that our businesses are the best that they can be, and we can truly achieve that world leader status. So moving on quickly through some of the tools that are out there and resources to support you in your work. We talked about evidence-based workplace accreditation schemes, so things like the Coventry Workplace Health Charter that you have as an example in the patch to build on. They provide a roadmap for employers on how to implement the evidence base. And we produce national standards so that across the country, all of those charters, the Better Work Award schemes, various different schemes that they are, have the same cake at the base. That's what the national standard is, it's the cake. And then you ice it based on your local need. And you can adapt it and build on it, but the basic cake recipe stays the same. And that supports employers who work across different patches to make sure they're judged in the same way. You'll see in the next week or two, the police will launch their version of a workplace accreditation scheme based on that cake of the national standards, which I think is called Oscar Kilo Charter, I think. And it was interesting because what they've done is they've taken the national standard and then they've iced it to enhance the support for people around mental health and very stressful situations. So that post-traumatic stress component that is unique to their service, they've added an additional criteria around that, and that's supported by Her Majesty's Inspectorate of Constabularies, who've woven the OK Charter into their inspection regime. So from 2018-19 onwards, the police will be judged as part of their leadership quality criteria against what they do on workplace health and their participation in this approach. And we'll be pulling all of these resources together onto a single page on .gov shortly. We commissioned RAND last year to do a review to look at actually can we show a bit more evidence about how these accreditation schemes work in practice, and these are just two examples which showing there was a meaningful difference to employers who were participating. We published a range of toolkits. We published the musculoskeletal toolkit actually last week, and there'll be two new toolkits on suicide which we'll publish at the end of this week, one for prevention and one for postvention. Really targeted at supporting employers, written in a business-to-business narrative. They were written and led by business and the community rather than by ourselves to help us make sure that we got the narrative right. Moving on to 1U, which I was great to see in the foyer while you were having coffee. Stand up again. You don't get away with just one standing up in a presentation like this. Okay, can you sit down if you've done the How Are You quiz? Okay, so those of you still standing, that's on your lunchtime break to-do list. Sit down. 1U was specifically designed with adults in mind. It was designed off the back of a narrative which said, it's great we're investing in children, and Sue is absolutely right, the children of today are tomorrow's workers. But the public sector requires the 14, 16-year-olds of today to be a hell of a lot fitter than they currently are. We need them to turn the curve in terms of lifestyle risk factors, in terms of lifestyle behaviours, in order for them to have a healthy retirement and a healthy older age, because we can't afford for them not to. So 1U is very much designed for 46-year-olds, although it is applicable to all adults. And a lot of areas, a lot of local authorities are amplifying it with local employers to use it as a tool to promote behaviour change and signpost people. There's a new app that we've soft launched, so it's not on the slide because this is kind of semi-secret information which I'm allowed to share, which is called Active 10. So Google it later. Active 10 is a walking app. What it does is it counts the minutes you do walking each day, and it tells you whether you're doing them briskly or not. So we know that in order for walking to be good for your health, you need to be going at least 3 miles an hour. Most of us have got no idea what 3 miles an hour looks or feels like. Even if you're doing it on a treadmill, it doesn't feel the same because you don't have the same visual cues of moving past things, so it's quite hard to judge. And what the app does is it gives you a readout and it shows you how many minutes you walked in total and how many of those were brisk enough to be improving your health. And then you only get a green star if you've done at least 10 minutes in a block of moving at 3 miles an hour. And it's that 10-minute block which is the kind of holy grail of physical activity. We want people moving that fast. So another homework for tonight is download the app and get people using it. I use it myself. It was really interesting. I was quite shocked. I walk a lot. On most days I average about 14,000 steps. What's interesting is actually of those 14,000 steps, only about 3,000 am I moving at 3 miles an hour or faster. And it's really helped me actually think about, am I moving fast enough? Although I'm on my feet a lot, it's probably not doing for my health what I think it is. And that's helped me change my behaviour. We've been working with NHS England, and I think this is a really good example about how the public sector can lead the way. The NHS and local government are massive employers in local communities, and therefore there's a real opportunity for us to work through them to do more. That's great. That's my 2-minute warning, so I'll speed up a little bit. There'll be a needs assessment tool we'll publish shortly to help employers think about the questions they ask to look at the health of their own population. And for larger employers, there's Britain's Healthiest Company and Britain's Healthiest Workplace, which is a free national scheme in which you apply to take part. You get a survey which is done at senior management level, and then a survey for employees. And one of the great things about this, and this is endorsed by the Chief Medical Officer, and we've gone through it quite a lot to work with Rand and Cambridge, who sit behind it, to look at the questions, is that it does help large employers see that disconnect that sometimes happens between we write beautiful policy documents, we have great posters on the wall, and we think we're completely walking the talk, and their staff who say, no one ever asked us, no one talks to us, it's, management are in a different space. And so it has these two bits, and the report triangulates in a confidential way for the business. So they get their individual report, and their names are only published if they're in the top 100 in the Financial Times. So it's definitely one to promote as well. We will be launching a call for evidence-based practice in 17/18. So we know that there's a lot of good stuff going out there. A lot of it looks really pretty, but not a lot of it's got good evidence base to show that it works. And we want to kind of change that narrative in terms of provision. And there are a range of reports and topic guides that have been published, as well as a new fingertips tool that's been gained. The next speaker is going to talk about LEPs, so I won't touch on them too much, but we have published a new fingertips tool, I think it was 2 weeks ago, on wider determinants of health. There's an entire segment of that which is on employment and health, and down to local authority, and it gives you comparators both with your statistical neighbours and within the region, so it's worth looking at. Another thing that might be worth looking at is the work that's been done by the PhD Centre in London, jointly with the Association of Directors of Public Health, which is a bit of horizon scanning, getting a sense of where were they going as a region and as a city, done through both desktop research, webinars and face-to-face focus groups. And they pulled out a series of clusters of drivers of change. And what I want to kind of highlight, these I'm sure will resonate across the West Midlands as well. They're common across the country. But within them, employment is one of the key ones, and health trends and financial climate. So this health, wealth and productivity narrative is there. And through that, they pulled out some of the issues that people were talking about, some of the connections between housing and work. You've got to be able to afford to live within a reasonable distance to get to your work. And we know that across the country, that used to be a very London problem. It's now much more an urban problem, an urban challenge moving forward. So there's work there that can be drawn on. Apparently they have a game. I haven't seen the game yet, or had a go to play it. But I know centre colleagues are engaging, so there may be opportunities for the West Midlands to get in that space. So finally, I'm just going to touch quickly on looking ahead to the future, because I think it's really important in this space of health, wealth and productivity to be looking forward as well as where we're currently standing. Some of the assumptions that we can take pretty much for granted: that life expectancy will continue to expand. 1 in 3 5-year-olds today will live to see their 100th birthday. If you're going to live to see your 100th birthday, you're not going to retire at 65. If you want to retire at 65, you should be saving 20% of your salary. I'm not going to get you to stand up and see who's saving 20% of your salary, because I'm pretty sure no one is. I certainly wasn't. Fertility rates will remain pretty much constant. There'll probably be some change in migration patterns, but overall there's a continuation of population growth. And although there'll be turmoil politically, economically, that actually individually there'll be a shift towards city-based living, and those city-based living approach will require us to think much more innovatively about sustainability, but also about social cohesion and community engagement. Now, I should warn you, futurology is not an exact science. It's one that PhDs kind of starting to dabble in. This is a prediction from the World Fair for a self-cleaning apparatus. And, of course, today we have a robot vacuum cleaner. So it's interesting how some of it plays out. You might not get it absolutely right, but you're in the ballpark, and actually being in the ballpark's quite important. There are a range of other contextual shifts around climate change, ecological sustainability, some issues globally around the sufficiency of water and food resources, the move towards the gig economy, that concept of the Uber driver, collective decision-making, the shifts we're seeing in political and democratic accountability, and all of this could drive increasing inequalities, and that's an important bit to keep in the back of our minds. There have been globally major changes in the patterns of employment, and this compares 1990 with 2010, and just to flag that the whitest service industries, and basically you see an expansion in 2010 of the proportion of businesses in each country that are attributed to services, and a drop in the amount that's attributed to agriculture. And then in between industries shrinking down in most countries, in some countries it's holding reasonably steady state. So the business world is changing. And if we continue on the current strand, we will see a greater plurality within the business space, people staying in jobs longer, people having portfolio careers, changing careers throughout a lifespan in work, which instead of being 45 to 50 years is likely to be 60 to 80 years potentially in employment. There will be new roles that exist and start to create. This is from a PwC report. What's interesting is Space Tour Guide 2025. 2 weeks ago on Facebook, there was the first announcement: the first 2 tourists will go into space next year in America as complete civilians with a tour guide. This job already exists. And if you think about your own lives and the people that you connect with, 10 years ago we didn't have Uber. Uber's about 5 years old, and this is its market footprint. The generation of the app economy, the gig economy, where people have multiple small jobs which connect to large chains of businesses. Who'd have thought we would have people whose paid employment was YouTube content creators? Those are jobs that didn't exist. The one I add to this list is 10 years ago, there weren't Zumba instructors. The world changes very fast. So looking ahead, the relationship between health, work and productivity is complex. It requires a whole system approach. There is no single agency that can solve the disability employment gap. There is no single agency that can solve job density and gaps around employment opportunities. It requires upstream solutions so that we weave into future generations through the way we teach them at university and at school, as well as the way we work with employers when they enter the workplace for the first time, to have a different approach to health and work and to productivity. And this integration is key not just for people entering the business sphere through traditional business qualifications, but it's fundamental to the way that we train and support healthcare professionals as well. There will need to be sector-led approaches as well as place-based approaches. We know particularly with small and medium business that sector-led approaches helps, that if you're a hairdresser you may or may not engage with your Chamber of Commerce. It will vary across the patch, but you probably do engage with the National Association of Hairdressers. similarly for grocers, similarly for plumbers. So actually there is how do we merge those approaches and make sure that we work as a jigsaw across the partnership to have an approach which is both nationally, internationally and locally led about connecting health, wealth and productivity. And we utilise those supply chains as we move as a business model to having national organisations with massive chains of small businesses. They already exist for some companies, but it's becoming more and more the norm. And the size of those small businesses getting smaller and smaller and down to individual sole traders. How can we use the cascade as a vector and a vehicle for change? Because at the end of the day, although the future feels a long way away, the future relies on what we do today. Thank you very much.